We'll go here and there. No? Okay, no problem. Good morning, everyone. Again, a ticklish question. In diabetic dyslipidemia, what should be the target levels as far as LDL is concerned? You all know by 2025, there will be more than 300 million type 2 diabetics. So many people with diabetes, naturally, it will be followed by an epidemic of cardiovascular, neurovascular, retinal and renal complications. Type 2 diabetes, which was once considered a disease of industrialized countries, but now a major health problem in developing countries also. My previous speaker told you about thrifty genes. That is the real culprit. Thrifty genes, which was basically for our ancestors to survive in scarce food conditions, but now it is producing thrifty phenotypes. Leptin, adenopectin, adipocin, resistin are the hormones which are encoded by this gene. Cytokines like TNF-alpha, IL-6, etc. are the other ones. Whatever you take, the ultimate thing in diabetic dyslipidemia is two: mismanagement of the blood glucose level and rise of the lipid levels with insulin resistance. We had a lot of discussion on insulin resistance, whether it is protective or deleterious, but most of the time deleterious, but it has some protective role also. Diabetes is not only characterized by elevated blood glucose levels, but so many other biochemical parameters also. Important cardiovascular risk factor in type 2 diabetes people is dyslipidemia, characterized by high LDL-C, low HDL-C, and raised level of VLDL and triglycerides. But this LDL level, which is very high, it is characterized by small, dense particles of the lipids, of the LDL, which is very atherogenic. If there is associated proteinuria, it causes more of stubbornness of the LDL-C to convert into more dense particles, hence become more atherogenic. There are elevated FFA levels associated with insulin resistance. All these causes triglycerides levels raised in the blood, which goes to the liver, converted into LDL, suppression of the HDL formation. Elevated blood glucose levels result in increased level of advanced glycation end products and generation of reactive oxygen species. Both of them, they modify LDL to make it glycated. And these glycated LDLs, they are taken up by macrophages to convert into foam cells. Similarly, some of the LDL is oxidized, again taken up by monocytes, goes into the vessel wall as foam cells. These foam cells, which are very laden with very dense, small LDL-C particles, ultimately causes atherosclerotic plaque. Again, there is endothelial dysfunction by suppressing the nitric oxide. Similarly, it stimulates the synthesis of MCP-1, then lipoprotein A levels are raised. As you all know, diabetic dyslipidemia is associated with CVD, with increased morbidity and increased mortality. There is premature and extensive atherosclerosis, poor prognosis in the first MI that showed by the Gusto trial. 5-year mortality due to CV event is 55% more in comparison to non-diabetics. At least 50% of the persons with diabetes have concomitant hypertension and dyslipidemia. Male, female. Females, they have more tendency for diabetic dyslipidemia in comparison to males, probably because of more visceral adiposity. So in nutshell, if there is diabetes and dyslipidemia combined together, there will be high triglyceride levels, 1.5 to 3 times, low HDL cholesterol, high levels of circulating cholesterol-rich particles having lipoprotein A and C3. Then you have oxidized and glycated LDL with increased foam cells in the vessel wall, insulin resistance, increased plasminogen activator inhibitor 1 levels causing enhanced thrombosis, then endothelial dysfunction by suppressing nitric oxide. All these will lead on to premature and extensive atherogenesis, leading on to increased cardio-neurovascular nephropathy and retinopathic complications. Is dyslipidemia in Indians is different? Yes. Triglyceride levels are higher, probably because of calorie-dense foods we take. HDL is still lower. Lipoprotein A level is higher in comparison to Western population. Now, what should be the target for LDL? ATP3 guidelines, primary target for therapy is LDL-C. Diabetes considered CHD risk equivalent. Patient with diabetes should have LDL-C level less than 100 milligram per deciliter. But if the patient with diabetes develop coronary event, then this LDL-C level should be less than 70 milligram percent. Patients with diabetes with CHD with additional risk factor, this has come into the ATP4 guidelines, which has been released now or is being released. They have considered additional risk factor like family history, smoking, previous stroke, etc. LDL-C should be less than 70 and at the same time HDL-C should be more than 50 along with low triglyceride levels also. ADA 2011 guidelines, again what they recommend, screening in most adult patients measure fasting lipid profile at least annually. Then adults with low risk lipid values, LDL cholesterol less than 100, HDL should be more than 50 and triglyceride should be less than 150. In fact, this thing has been taken into consideration. If there is a diabetic dyslipidemia along with coronary event, along with additional risk factors, the cholesterol, LDL cholesterol has to be brought to less than 70, HDL more than 50 and triglyceride less than 150. 2013 ACC-AHA guidelines. All these studies, you take all these studies, ultimately what they say, if there is no diabetes, LDL-C should be 100 to 130 milligram percent, screen every year. With diabetes, LDL-C should be less than 100 milligram percent, screen yearly. Diabetes with CVD, LDL should be taken as less than 70, screen 1 yearly. Diabetes with CVD with additional risk factor like smoking, family history, low HDL, hypertension, LDL should be less than 70, HDL should be brought up to more than 50 and TG level should be brought down to less than 150. Now, what should be the treatment strategies, what they have recommended? Primary strategy is to lower the LDL cholesterol. Secondary is to raise the HDL and lower triglycerides. Then there are the other approaches. Two important aspects, lifestyle and statin base. On the risk calculation, this is the ADA 2015 guidelines, which I will come to a little bit later also. For non-pharmacological treatment, increase physical activity, reduce the proportion of saturated fats in their diets, increase consumption of high fiber carbohydrates, and reduce your body weight. I will devote a little time to lifestyle management because this is the mainstay of diabetic dyslipidemia management. Whether you take statins or not, but this comes with the topmost priority and as the number one. Increase your physical activity. Dietary guidelines, ATP3 and ADA clearly says Your saturated fats in diet should have been less than 7% of the total calories. Weight reduction by 10% of the initial body weight remarkably controls glycemia and lipids. First A approach is low carbohydrate diet will improve lipids by lowering the triglycerides. The Foster et al. Has reported 28% reduction in TG after sustained 12 months of low carbohydrate diet. Second approach is use high protein diet, means 30% of the total calories, moderate amount of carbohydrates and optimal amounts of the fats. Third approach is reduction of the saturated fats, restriction of simple sugars, starch and alcohol, which promote weight loss and improve all the parameters. And omega-3 oils significantly reduce triglycerides while having a neutral effect on LDL-C and HDL-C. Among the dietary guidelines, one of the most important things in our Indian population is you have to reduce your food intake, especially the carbohydrate intakes, increase some amount of proteins in your diet, and restrict your fat content of the diet to less than 30%. Very familiar triangle of the diet, what to take more and what not to take. I will give one specific thought on this slide. Liquids, all carbonated drinks, sugary sodas, sweetened packages, juices, opt for milk, charge, fresh fruit juices, soups or green teas. Superfoods like dry fruits, nuts like almonds, cashew, walnuts, prunes to be taken in right quantities, and it should be part of your daily intake. Many of the misconceptions in our Indian population is the nuts, to avoid nuts or nuts altogether. Even groundnut and cashew nuts have been found to be quite useful in diabetic dyslipidemia. Protein nutrition, 1/4 portion should be of proteins like beans, legumes, fish, egg, white, lean meat, milk and milk products. Grains, opt for whole grains and use by mixing like wheat, gram, millet or ragi, etc. Now the concept is don't use the grains in a single way, but mix it with other grains and make it a multi-grain, which you take either flour or even the rice also you can mix other grains. Then green quarter should be 1/4 of the plate should be of fresh vegetables, raw, roasted or cooked in minimum oil. Fruit quarter should be 1/4 of the plate, and it should contain fresh fruits, especially the seasonal ones, because the seasonal fruits, they have more nutritive value and lesser of the carbohydrate or lesser of the preservatives. Oils and fats, avoid fully or partially hydrogenated fats. Opt for traditional oils like olive, rice bran, curdy, sunflower, sesame, coconut, desi ghee and butter. You can use now, but it should be used in less than 7% of your calorie intake. In plenty, you should take all these things. Stop it. The processed food like pizza, burgers, excessive fried foods, that should be stopped. Lean meat and fish should be taken, it's okay. Red meat and yellow of the egg should be avoided. Nuts are okay. Then oil, canola oil, olive oil, safflower, whatever you want to take, that is quite okay. That should be a rightful combination of the PUFA and MUFA. And if you mix two oils, it should give you a good combination of MUFA and PUFA. But still, if you want to consume only one oil, then change that oil after 4 or 5 months. Alcohol, replace alcohol with your life. Alcohol sometimes is okay, but in very limited quantities, what the literature says. But those people who are, because sometimes in your clinic the patient comes that they say that alcohol is good, wine is good, whether I should start taking the alcohol? No. If the person is previously not taking alcohol, he should not be encouraged to take alcohol. Smoking, stop smoking altogether. Yoga and meditation. Buy yourself the time you deserve, because the time is very costly, and it is the time which gives you mind relaxation, ultimately the body relaxations, release of less of catecholamines, and ultimately all the biochemical parameters, they are relaxed. Relax and enjoy your holidays. Now, therapy for we come to medical therapy. That was as far as lifestyle is concerned. Statins, niacin, fibrate, BSAs, omega-3 fatty acids, and ezetimibe. All of them, they reduce triglyceride, LDL-C levels, raise HDL-C levels, but statins are the most frequently used, most extensively studied, and shows the most promising results. Now, what the ATP3 and ADA guideline says. Statins are the first line drugs for treatment of diabetic dyslipidemia. Statins, they lower the LDL-C by around 20 to 60%, VLD and triglyceride by around 20 to 30%, and increase HDL-C by 5 to 10%. Currently, 6 statins are in extensive use. They have been grouped into 2. Less potent means reduction of LDL-C by 20 to 40%, like fluvastatin, pravastatin, and lovastatin. More potent LDL-C reduction by around 30 to 60% by simvastatin, atorvastatin, and rosuvastatin. These 6 statins are now in extensive use all over the world. In general, all statins are remarkably safe, except for very high doses on prolonged use may cause fibromyalgias, but they are remarkably safe. All statins cause myalgias and proteinurias, but they are transient and not harmful. It resolves if the drug is withdrawn. What the ATP4 guidelines say, they have divided into high-intensity statin therapy and moderate intensity statin therapy. If you have to lower the LDL-C on an average by approximately 50%, you have to use high-intensity statin therapy. That is atorvastatin 40 to 80 milligram, rosuvastatin 20 to 40 milligram, especially in cases like acute onset of myocardial infarction or strokes or peripheral vascular disorders, where there is a little bit of emergency situations. You can use high-intensity statin therapy there. But if you want to go a little bit longer time you want to take and want to reduce a little bit slowly, or the situation is not warranted in that way, you can have moderate intensity statin therapy, where you will lower the LDL-C by average around 30%. Atorvastatin 10 milligram, rosuvastatin 5 to 10 milligrams, simvastatin 20 to 40 milligrams, like this. But ATP4 guidelines say very clearly the first line of management is, again, the lifestyle and statin therapy. Fibrates we have, gemfibrozil and fenofibrates. I will not go into the very details, you all know. But fibrates, the main funda of using fibrates is it lowers the triglyceride level much better than statins. So if ATP4 guidelines clearly say that you should use only statins, but if the LDL-C is not coming down and the triglyceride is still creating a problem, then you should add fibrates to that patient. Niacin, it is an excellent drug to raise your HDL-C levels. Very excellent drug. But unfortunately, just because of its side effects, it was not used extensively and still being not used extensively. Just because of its side effects. Otherwise, it is an excellent drug to raise your HDL. Ezetimibe, it was used quite a lot few years back, went into disrepute, again now being remarketed with some good effects on lowering of triglycerides. Omega-3 oil, one word about that. Purified omega-3 oil reduces the triglycerides with neutral effect on LDL-C and HDL-C. It regulates the activity of nuclear receptors causing beta oxidation of fatty acids, has potent anti-thrombotic and vasodilatory effect by decreasing the platelet aggregation and increasing the thromboxane A3 levels. In fact, it is recommended that 1 to 4 gram per day of omega-3 oil or increasing the fish consumption to 2 dishes per week will give you good amount of omega-3 fatty acids in your blood. Bile acid sequestrants not used extensively in our part. I will go back to one slide. This slide. If there is no diabetes, LDL-C should be 100 to 130 milligram. Use therapeutic lifestyle changes. This will suffice to keep the LDL-C level at this place. But if it is with diabetes, screen yearly. TLC means therapeutic lifestyle change. Statins you have to give. If this is sufficient, by this time you can stop. If it is not sufficient, you can add fibrates. But still, if it is stubbornness, then you can add niacin. Similarly, with CVD, you have to give TLC, then intensify the statins. Go from moderate to highly intense, as per ATP4 guidelines. But if the situation is not warranting, do not go very aggressively in lowering HDL-C. Give a little bit time to your body to adjust to that. Similarly is this, you have to use almost all the 4 parameters. So take home message is, I'm just concluding it. Yes. One word about the future drug. This is darapladib. It is the second novel drug which inhibits lipoprotein-associated phospholipase A2. It is showing very good, promising results, but still not in the market. Take-home messages: diabetic dyslipidemia is a major health concern. Since India is the diabetes capital, majority of the diabetic patients in India suffers from dyslipidemia. Diabetic dyslipidemia is characterized by elevated LDL-C, elevated triglyceride levels, low HDL-C, insulin resistance, increased plasminogen activators, and endothelial dysfunctions. The major goal in diabetic dyslipidemia is LDL-C should be less than 100. If it is with CVD, the LDL should be less than 70. Lifestyle management is the mainstay. Statins are the first-line drug for the management of diabetic dyslipidemia. Fibrates, niacin, ezetimibe, omega-3 oil are the other choices. Among the statins, fluvastatin, pravastatin, lovastatins are in low potency group, whereas simvastatin, atorvastatin, rosuvastatin are in the high potency group. It happens only in India. These are the few images collection which shows that we are one of the jugadus as far as this country is concerned. And now thank you very much.